Hello and welcome to our webinar today. Our presenter today is Don Mitkus, and he will be talking a little bit about substance use, abuse, and dependence today. Uh, I always want to encourage you to contact us and let us know if there are other topics you'd like to see covered in one of our webinars. You can contact me at my email address, dale.gasparovic@prevention.org. You can also follow us on Twitter at SACenterPF, or you can email me at that same email address to join our Student Assistance Center group site, which has a number of people who are student assistance professionals involved in that. You can have conversations. You can check out new resources that are posted there, and you can connect with other professionals with questions and discussion around student assistance topics. As I said, our presenter today is Don Mitkus, and I'm going to turn it over to you, Don, right now to begin our presentation.
All right. Great. Thanks, Dale. As Dale mentioned, my name is Don Mitkus. I'm a licensed clinical professional counselor and certified reciprocal alcohol and drug counselor. And it's not on there, but I'm also a certified student assistance professional. I work with Dale at as a consultant for the Student Assistance Center. Have done a number of webinars for Prevention First. And today, what we're going to be talking about is identifying substance use and addiction or dependency. And we're going to cover it from a couple of different angles. Sometimes it's obvious when you're presented with a student that has the clues are pretty glaring that they might have an issue or be developing an issue with alcohol or other drugs. Sometimes the clues are a little bit more subtle, and sometimes you may be called upon to give your opinion on whether or not a student is under the influence, depending on your position in a school. So if you're a resource officer, school nurse, counselor, social worker, you may have a dean walk a kid into your office and say, you know what, I think this kid is high. What do you think? So we'll be covering a little bit of that as well today to give you some tools to help you take a look at someone and say, hey, you know what, this might be going on. So our goal today is we're going to identify symptoms of impairment from substances, both physically and behaviorally, and we're going to distinguish between use, misuse, and dependence. So with that, we're going to start out with defining use, misuse, and dependence. And please note, for the purpose of this discussion, of this part of the discussion and presentation, the differences between use and misuse and chemical dependency or behavior, the type of chemical or the type of behavior is not consequential, because what we have found as a therapeutic field is that the symptoms, the signs of someone who has a substance use disorder, mild, moderate, or severe, or chemical dependency, is very similar no matter what the chemical or behavior is. So someone who is has a substance use disorder diagnosis for marijuana, their behaviors and symptoms are going to look somewhat similar in some ways to, generally speaking, to someone with an alcohol use disorder or a cocaine use disorder. So the signs and symptoms are very similar across substances and mood-altering behaviors, but we are going to get into the specifics of the general classifications of drugs and how that impacts someone's course of developing a use, misuse, or dependency issue. So, use. Technically, for adolescents, for those under the age of 21, there is no safe level of use in regards to mood-altering substances. There's just not. Use is, and this point can be argued, but from a developmental perspective, one of the reasons, not just a legal perspective, but from a developmental perspective, introducing a mood-altering chemical into the central nervous system, into the brain, any type, while the brain is developing, it carries risks and potential consequences with it. So we don't really look at use for adolescents as a accurate category. That being said, most adolescents, statistically, are going to experiment with mood-altering chemicals. The job of adolescents, for developmentally speaking, is to develop as an individual, develop a personality, develop a sense of who they are as an individual, develop a sense of what their passions are, what interests them, what doesn't interest them, and discover things that make them feel good and things that make them feel bad, and do more of the things that make them feel good and do less of the things that make them feel bad. So mood-altering chemicals is one way that many adolescents choose to experiment with what feels good and what doesn't. There's no mystery to why people use mood-altering chemicals, because they, generally speaking, in an immediate sense, feel good. Even though there might be consequences afterwards, the immediate effects tend to, in small amounts, tend to be pleasant. So the thing about an experiment is experiments are time limited, typically. When a scientist engages in an experiment, the idea is not to endlessly test for the same type of data over and over and over and over and over again. The idea is to experiment, collect data on a particular theory, right? You theorize that based on available information, that alcohol will help me have a good time. That's your hypothesis. And an adolescent may engage in drinking alcohol to see if it will indeed help them have a good time. Now, they engage in this behavior a few times. They try it out 2, 3, 4 times. They have to a greater or lesser extent, they'll change some of the values, such as how much they drink, and we'll look at at some level be subconsciously looking at the results. If they have a good time, their conclusion is alcohol does help me have a good time. If they drink too much, well, gosh, that was terrible. I threw up. I got in trouble because I came home late. All these things, and that is also data for them to form a conclusion. Now, after they've collected data on a few occasions, again, 2, 3, 4 times, they will come to a conclusion. Yes, this is something I like to do. No, it's not something I like to do. This is something I want to do a lot more of. This is something I don't want to ever do again. At that point, the experiment is over. The experimental stage of use, it really is very time limited. They collect their data, they make a conclusion, and then they decide whether or not they're going to continue to be involved with it. So anyone who tells you that, well, I'm just experimenting, I just smoke pot on the weekends, or a couple times a month, but it's been going on for the past 3 or 4 years, that's not an experiment. That is continued use. So misuse. We recently had in the past couple of years, had a shift in the therapeutic community where we went from the DSM-4, which is Diagnostic and Statistical Manual. That's the thing that has all of our psychiatric diagnosis in it, including substance abuse and substance dependence. That's DSM-4, version 4. A couple years ago, DSM-5, or the fifth revision, came out, and we moved away from the diagnosis of substance abuse to a substance use disorder with a range of mild, moderate, or severe. Now, here's the thing about a substance use disorder. You can the key, the crux of the matter for an adolescent, for a teenager, for anyone really, adolescent, adult, to qualify for a substance use disorder, and again, it doesn't matter what the substance is that the real crux of it is that they continue to engage in using that substance even though they experience negative consequences. So even if a real issue or problem in their life can be attributed to their use of a chemical, directly linked to it. A very obvious case is getting a DUI. You know what? I got a DUI. That was terrible, and it doesn't alter their choices in regards to alcohol use. They continue to use despite a really significant negative consequence. That's the crux of having a substance use disorder, meaning that there's typically some sort of intervention that should occur in order to get them to change or alter their behaviors. So for an adolescent, we tend to see negative consequences accumulate or happen in these primary areas. School. It's difficult to engage in regular use of a mood-altering chemical and maintain the same level of academic performance that you exhibited previously. So now there are some kids that have significant academic talent and can engage in some regular substance use and don't necessarily lose that edge or that 5-10% of academic acumen that they lose with regular use of a mood-altering chemical and still maintain A's and B's, not a problem. For the kids that really had to work to maintain C's, regular use will make it difficult for them to make that effort to maintain an average GPA. And then those C's become D's or F's. The choices of at school of whether to go to school or not after just a weekend of significant partying, that becomes a choice. Accumulation of absences, choices about behaviors at school, in regard to being caught at school with paraphernalia, being caught at school under the influence. These are things that happen. You make more riskier choices as you choose to incorporate using a substance more and more into your life. So the risk may not seem as risky to go to school under the influence as it did 6 months previously. So even though they may get caught or they may get suspended or might be an attendance review board, poor report cards, even if they're accumulating these issues or problems at school and they continue to use, there's a disorder there. Socially, changing in friends, changing alignments of their social groups. We surround ourselves with people who, in adolescence, we surround ourselves with people that support the choices that we make. The concept, frankly, I think the concept of peer pressure is a bit of bunk. It takes away the personal responsibility from that adolescent. There's peer influence, but there's also the peers we seek out that are making the same choices we are, therefore are supporting and are supportive of the choices we're making in regards to our chemical use. So there might be a change in alignment of friends, moving away from friends that are not doing the same things that they're choosing to do, and moving towards people that might be doing the same, if not more, than what they're doing. Family, getting in trouble at home, coming home late for curfew, breaking house rules, house expectations, increased arguments, hiding things, lying, all those things that are damaging to core relationships start to accumulate when someone decides to continue to use, even though they know that that's not consistent with their family's values. Legal, I mentioned DUI, getting arrested for having paraphernalia, being arrested for public intoxication, getting a ticket at a party for underage drinking, or being present just being at a party where there's alcohol involved, they can get a ticket, which can again downstream have an impact on school if they're involved with athletics or extracurriculars, and they have a code of conduct at their school that requires them to be suspended from extracurriculars or sports because they made a choice in regards to alcohol or drugs that got them in trouble with the law. Internal. Even though you may experience, an adolescent might experience feelings of guilt or shame or regret, feeling down, depressed after making the choice to use a particular drug, or about choices that they made when they were under the influence, despite having these really strong negative emotions, continue to drink or use other mood-altering chemical. Again, that is a sign that someone has a substance use disorder or is misusing a particular chemical. Which brings us to chemical dependency. So aside from, and this is where the rubber meets the road as far as when significant intervention is needed, is when someone moves from the area of misuse or mild or moderate substance use disorder and moves into the severe area or the dependency area of chemical involvement, mood-altering chemical involvement. So when chemical dependency is developed, when they move into that area, and there's we don't have a set demarcation line where someone moves from misuse to dependency. We just can diagnose when they are there. We have some not just behavioral negative consequences from their behaviors and their choices, but now we actually have some biochemical changes that occur in the brain and the body because of this chemical assault that their body is under, where repeated exposure to mood-altering chemical with enough frequency or intensity, or with a chemical that's more potent or has a more potent addiction potential, the body and the brain will actually go through some biochemical changes to adapt to that. The descent into dependency is very slow and gradual with drugs such as marijuana. But the descent into a chemical dependency can be extraordinarily rapid when you're talking about potent chemicals like heroin or crystal meth. These can cause some very significant biochemical changes within the first few uses. So these folks, when you develop a chemical dependency, some very significant intervention is needed to help them make some changes, because you're not only dealing with helping them make different choices to avoid, to start fixing some of those negative consequences that they've built up, but you're also dealing with the body's reaction to the absence of the chemical, which could be a significant withdrawal, where you might, for someone who's dependent on heroin, has a dependency on heroin physically, the withdrawal is much like the worst case of stomach flu you've ever had, multiplied by 5. It's very painful and very uncomfortable, and it drives people to go back to using because they'd rather use and to be able to avoid those withdrawal symptoms. To more subtle withdrawal effects, like with marijuana, you can have some pretty prolonged withdrawal from marijuana, but the symptoms are more subtle, not as spectacular as with alcohol or with heroin or other opiates. So with marijuana, withdrawal can be slow and gradual, but can include some significant mood instability or difficulty dealing with strong and powerful emotions, some trouble with memory retention, things of that nature. So more subtle, but still has an impact, and impacts someone's ability to learn new ways to cope, or new ways to make new choices to make when they're trying to, if they are indeed trying to stay clean or have to stay clean because of legal involvement or family mandate. So that kind of covers the range from use to misuse to chemical dependency. And the thing about dependency too, and I've alluded to it previously, and we'll talk a little bit more about this, is that there are also behavioral processes that are that potentially can be addictive. That can also cause actual biochemical changes in the brain, just by the behaviors, even in the absence of the chemicals. So we'll talk about that. So seeing the signs, what do you look for when you're presented with someone who might be under the influence, or might be, what do you look for what clues do you look for to help determine what am I dealing with here? So there's three main categories of mood-altering chemicals. These are central nervous system stimulants, central nervous system depressants, and central nervous system psychedelics. We're going to go over each of these categories and what kind of falls underneath each of them. There's a fourth non-chemically based mood-altering category, and that's behavioral processes. That includes things like gaming, gambling, internet, pornography, food. If the behavior alters mood, and things like, for instance, gambling can cause a significant mood alteration simply by engaging in the activity, there's a potential for addiction there. We call them process addictions. Can be just as devastating as any chemical addiction, just as devastating, if not worse. So looking at central nervous system stimulants. So stimulants include drugs like tobacco, prescription stimulants, majority of your attention deficit hyperactivity disorder medications like Ritalin, Dexedrine, Vyvanse. These are all stimulant-based medications. Cocaine, crack cocaine, ecstasy, crystal meth. These are all, or crystal methamphetamines. These are all drugs that are central nervous system stimulants. And in general, what central nervous system stimulants tend to do is they speed up the central nervous system. So that includes your parasympathetic nervous system, like your heart rate and your breathing. They tend to increase in frequency. It causes the brain to release, and this is what causes the high, it stimulates the brain to release large amounts of dopamine. The more powerful the stimulant, the greater the release of dopamine into the brain. Now, dopamine is a neurotransmitter. So what that means, it's a brain chemical, and each brain chemical you have has a different function. So endorphins, for instance, are your brain's natural opiates. So these are, when someone talks about the concept of a runner's high, they run and they get to a certain point, and they just feel this sense of well-being and relaxation wash over them. Well, their brain has just released a bunch of endorphins, and those endorphins go and sit on the opiate receptor sites in the brain and cause this feeling of well-being and relaxation. Well, with stimulants, it releases causes the release of large amounts of dopamine, and dopamine is what regulates how up and good we feel. So when you introduce a mild stimulant like tobacco, that's, you get a mild rush. But when you have a powerful stimulant like crack cocaine, the amount of dopamine that's released is enormous, and the high is very, very high. Now the thing is with the release of dopamine is that the release is quick, and the effects of the drug are quick, and they do go away fairly quick, especially with the more powerful stimulants like cocaine or crack. So you have this great high, and then you have a just as low low. As high as the high has gotten, you will have a crash that's pretty low. Now here's the what happens in the brain, and when you have powerful stimulants like cocaine or crack cocaine, you develop your brain will very quickly develop this reward pathway that use this drug, large amounts of dopamine are released, and wow, that feels really good. We like that. The brain goes, hey, that's fantastic. I feel great. So when you come down and you crash, the brain goes, oh no, we don't want to feel like this. But the brain is very pain avoidant. So it's going to send you signals to say, avoid pain, because pain is hurting us in some way, and it could be doing damage to our physical body. So, avoid pain, like, gosh, you're too close to that hot stove, move your hand away. And it happens involuntarily, but it's your brain's way of saying, hey, let's avoid pain, because pain really stinks. So when we crash off a powerful stimulant like cocaine or crack cocaine, for instance, the brain goes, wow, this is not good. We don't want this. What can fix this? Oh yeah, didn't we just feel really great? Well, use that again. So the craving that then becomes hardwired into the brain is, if you feel bad, use this drug. That's the message. Your subconscious, your really primal part of your brain is going to keep sending you. Your conscious part of your brain is, this is feels really good, so keep doing that. So very powerful stimulants can very quickly create very strong reward pathways in the brain that anytime that someone is feeling bad, the brain is going to send them a signal that, in the form of a craving, saying, hey, this is really the best way to tackle this particular problem, is to use this particular drug. So stimulants can, powerful stimulants can have a pretty high addiction potential. So now when someone is under the influence of a stimulant, as I mentioned before, they speed things up. So that in the central nervous system, the brain, the parasympathetic nervous system, so their breathing tends to be more rapid. Their speech tends to be more pressured or quick. Their heart rate tends to be elevated. Their blood pressure tends to be elevated. And there's an old saying amongst some police officers I know, that the eyes are the window to the soul, or to the drug, so to speak. Whenever you're looking at have someone in front of you and you're looking to see, it's like, what might I be dealing with? One of the best places to start with is the eyes, because the eyes are very, very reactive. They're the most actively reactive muscle systems in your body are in your eyes, and they reflect the things that are going on in the central nervous system. So, when you watch any hospital-based TV show, and one of the first things they're doing is they're checking the heart rate, and then they're looking in the eyes, right? Let's check the eyes. So the same goes with central nervous system affecting mood-altering chemicals. Stimulants tend to cause the pupils, the black part of the eyes, to dilate, to get much bigger. It's a side effect of being under the influence of a stimulant, is the pupils get very large. So if you have someone that's fidgety, anxious, difficulty sitting still, and their pupils are really large, chances are they're under the influence of a stimulant. The next category is central nervous system depressants.
Don,
So, yes.
before you move on from the stimulants, one of the things that we know is a lot of times students are not using these particular drugs in school.
Hmm.
Could you talk a little bit about what we might see with a student who may be crashing from one of these stimulants?
So, thanks, Dale. Yeah, absolutely. What one of the one of the things that's a particular concern in high schools, particularly in colleges and universities, is the abuse of the prescription stimulants. Unfortunately, we've got a rash of kids that are of overdiagnosing things like attention deficit disorder. So there's a lot of Ritalin or Vyvanse or other stimulant-based medications, pills floating out there. So this is something that is being used as study aids. Your high-performing kids that are trying to get through 6 AP exams or AP classes and the exams, and then the AP exams or finals or quarter grades. They will use these to stay up and focus and study. The problem is that there is a crash that's involved. So students that in the morning are lethargic and might be walking around with a 24-ounce cup of coffee or a triple shot latte from Starbucks, and are slugging them down, but are still lethargic and lackluster, flat affects, meaning that there's just not a lot going on there emotionally in their presentation. These tend to be the after an irritability and moodiness. So when questioned, can be very irritable and snappish. That's if you've known someone that drinks a lot of coffee and on a daily basis and decides they're going to quit, or someone who has stopped smoking, amplify that moodiness by a couple of factors, and that's that you have someone who's been using stimulants for unintended purposes, sleeping for long periods of time. When you have the more powerful stimulants like cocaine or crack cocaine, binges become a real possibility, where they will use the drug on a consistent basis for hours and hours and hours, and they'll crash, and that crash can last 24, 48 hours. So and then they're not in school. So the after effects tend to be the opposite of what the effects of the drug are in regards to stimulants. So with central nervous system depressants include things like alcohol, prescription pain medications, and heroin. It causes the central nervous system to slow down. There's a much more significant risk, medically speaking, with ingesting too much of a central nervous system depressant than there is with a stimulant. Although you put yourself at risk for a cardiac incident or a stroke, and you use large amounts over a long period of time of a stimulant. The thing about a depressant is that in an immediate sense, you can slow down your central nervous system to the point where you've depressed your breathing and your heart rate, to the point where things actually stop working in the body, and you're in a real crisis situation. So alcohol overdoses are unfortunately becoming more and more frequent in our ERs. The amount of prescription pain medication that is being used recreationally, because it's easy to access for adolescents. Anytime that a parent has had a root canal or twisted a knee or has some back twinges, they're getting 30 tablets of Vicodin or codeine or Darvocet, and like most people, you use it for a little bit, and you might just put the rest away in case you need it at some other point, or put it away, put it in the medicine cabinet and forget about it, which is the easiest point of access for any adolescent. It's no longer the liquor cabinet. Well, it's still a liquor cabinet, let's face it, but it's also the medicine cabinet. Prescription medications have this veneer of being safe because doctors prescribe them, so they must be okay, or safer to use than illicit drugs, when the fact is the risks are pretty significant. The thing about prescription pain medications is they are, most of them that cause significant mood alteration are opiate based. And something else that is opiate based is heroin. So we have seen a number of kids who have made the transition from partying with prescription painkillers to heroin, making that switch, and fairly easily too. The unfortunate thing about opiates is they are also very highly addictive. Their addiction potential is significant. And the reason is that your body develops a tolerance to opiates pretty quickly. And the thing about tolerance is your body's reaction to medication or a mood-altering chemical being in your body consistently. So it makes adjustments. In the case of opiates, it increases the production of certain neurotransmitters and increases production of certain liver enzymes. Now, when you stop using the drug or you don't put the drug into your body doesn't stop producing these additional neurotransmitters or liver enzymes. And consequently, when you don't have the medication there, that's interacting with these biochemical processes, you experience withdrawal. Your body is going, well, your body's reacting to these additional enzymes and additional neurotransmitters that are floating around looking for opiates to interact with. And you experience withdrawal that is, I think, as I mentioned before, similar to a stomach flu, but like the worst case of stomach flu you've ever had in your life, multiplied by 5. It's very, very painful and very, very uncomfortable. And again, the body is pain avoidant. So if the brain at a subconscious, more animal level says, you know what, you need to fix this because I'm in a lot of pain, so something must be horribly wrong. And the way I know that I'm going to fix it is if you put some more of that stuff in us, that's going to take it away. So go do that. So the cravings are very strong. The high is very high and intense, and the crash is significant. So the reward pathway that is formed pretty quickly, typically if regular use occurs within a 2-3 week period, you can very easily develop a dependency in that period of time. Alcohol is a little different. Alcohol works differently than opiates do, even though they both suppress the central nervous system. If you take both in a larger enough amount, you will depress your parasympathetic system, such as your breathing and your heart rate. Opiates like prescription opiates and heroin work on the endorphin receptor sites in your brain. Alcohol affects every cell in your brain. Alcohol depresses the functioning of every and irritates every cell it comes into contact with. So what it does is that alcohol will, as your blood alcohol level increases, put your brain to sleep in stages. So the first part of your brain that goes to sleep, and typically within a couple of drinks within an hour, and a drink is defined as a beer or a glass of wine or a 1 ounce shot of 100 proof liquor. Within a couple of drinks or more in an hour, the first thing, the part of your brain that goes to sleep is your frontal lobe. The good idea, bad idea part of your brain, where your executive functioning lies. That's the first thing that is impaired as you introduce more alcohol into your system. And then other parts of your brain start to be impaired by alcohol is if you're not giving your body enough time to process the alcohol you're putting in out, and it can only do so at a certain rate, your blood alcohol level will continue to rise. So, behaviors that are not wholly uncommon amongst adolescents include things like beer bongs and keg stands, and doing multiple shots at the same time, or beer pong, where there's large amounts of alcohol being consumed in a short period of time. Blood alcohol levels can go up pretty quickly. After the frontal lobe goes to sleep, your small motor function, your fine motor function becomes impaired. So the small motor function or fine motor function includes things like handwriting. It includes things like speech, because speech requires the coordination of a lot of fine muscle control. So someone with the blood alcohol level above about a 0.10, 0.12 will start to slur their speech, because their brain is not awake enough to coordinate everything that needs to happen, that you're trying to get at your face and your mouth and your tongue and your lungs and everything else to do in order to speak clearly as you would if you were unimpaired. The next thing that goes to sleep is your gross motor skills, balance, walking, driving, all these things that require large muscle group coordination becomes significantly impaired. Now, driving, of course, it becomes impaired with the fine motor skills, and then after large motor function becomes impaired, your autonomic motor function becomes impaired. That's when people start passing out. If during that stage, if another large amount of alcohol is introduced, they can go from, because passing out is one of your body's defense mechanisms against alcohol poisoning, is, holy crap, look what you're doing, we're in a crisis situation here, we're just going to shut down, or it causes you to throw up, to expel the alcohol, to try to keep more from coming in. All these systems do become depressed and impaired with greater amounts of blood alcohol content. So if you have someone that's very intoxicated and then drinks another large amount of alcohol, they're at real risk for alcohol poisoning, where their respirations or heart rate become so depressed that they can find themselves not breathing. So immediate alcohol impairment. So how do you know? Even with small amounts of alcohol, there are signs that you can look for, aside from just the odor of it. So if you remember that TV show Cops, it's almost every episode they're dragging someone out of a car and making them walk a line, right? To look for obvious signs of impairment. So some of the things that they're looking for, as far as are gross motor impairment and fine motor impairment. There are some things that you just can't control when you're under the influence of alcohol. Balance is one of them. If your balance is impacted because your blood alcohol level is pretty high, you're not going to be able to walk a line very well. As I mentioned before, the eyes are kind of the windows to what's going on internally. So one of the things that you can do, and one of the things that happens when the blood alcohol level gets to about a 0.08 or 0.10, which is 0.08 is the legal driving limit, but what occurs is a person will experience what's called nystagmus. So what that is that if you've seen those field sobriety tests where they're moving a pen or a pen light back and forth and across someone's field of vision, they're asking them to track that light or that pencil or that pen with their eyes without moving their head. That's what they're looking for, is nystagmus. If someone is sober, they can track it back and forth perfectly smoothly. Their eyes track back and forth normally with no hitches or glitches, so to speak. But as someone's blood alcohol level goes up, they experience nystagmus, where it can't track it smoothly and it starts to skip or jump as it moves back and forth, and that's called nystagmus. So the more intoxicated someone is, the more the nystagmus is occurring. So it's something to look for when if you're assessing whether or not someone might be immediately under the influence is nystagmus. So with opiate intoxication, however, if someone is immediately under influence of if they're high on an opiate, they tend to present in a kind of a sleepy, dreamlike state that we refer to as being on a nod. They might have difficulty staying awake. Their head might be nodding, so to speak. And looking at the eyes, the pupils tend to be very, very pinpointy, very, very tiny. The blacks of the eyes are like pinpricks. So that's a sign to look for that someone might be under the influence of an opiate. It's very, very difficult for someone to maintain any sort of academic ability if they're significantly involved with an opiate. It's very difficult. Absences tend to be high. Grade and academic performance tends to be impacted pretty significantly. There's no such thing as a social heroin user. There's just not. This is a very potently addictive drug. And for better or worse, for worse, we've seen a significant rise in it in both Chicago and the Collier counties. So it's something to be on lookout for. Now, it's still not as prevalent as alcohol or marijuana use, but it is something that we need to be aware of and be vigilant about. So the third classification of drugs are central nervous system psychedelics. Some refer to these as hallucinogens, but we tend to use the term psychedelics because not all psychedelics cause hallucinations. But what drugs like in this category are drugs like marijuana, LSD, mushrooms. And what they do is they cause distortions in the perceptual areas of the brain. So they alter our perception of the world around us to a greater or lesser extent. The reason marijuana is included in this category as opposed to a depressant is marijuana doesn't depress the functioning of the central nervous system. What it does do is it alters our perception of the world around us, particularly alters our perception of the passage of time. So it's someone under the influence of marijuana, someone who's high, it tends to impair their coordination, their visual tracking, and time perception. So how is this useful to you? Is that it can help you in determining if someone's under the influence by some field sobriety tests. So one of the tests that I had used was I would ask a student who I thought might be under the influence to close their eyes and tell me when they thought 30 seconds had passed. So closing their eyes so they don't have visual cues like watches, clocks, cell phones, whatever. But tell me when 30 seconds had passed. Usually 2.5 minutes later, they're like, oh yeah, that's 30 seconds. So we all have internal clocks. We all have a general, in the absence of an impairment, have a pretty good general sense of what time of day it is, passage of time. Yeah, it was about 5 minutes. That was about 15 minutes. That was about an hour. But being under the influence of marijuana will alter that perception of time passing. It also impacts visual tracking. So as we talked about with alcohol, moving something in front of someone's field of vision back and forth, if there's that jumpiness in their tracking, that's a clue that someone's under the influence of alcohol. With marijuana, their tracking is maybe smooth, however, it's behind the object. Their eyes aren't necessarily locked on the object. It's lagging behind a little bit because it also impacts our visual spatial perception. Marijuana does. In the third, there's also an involuntary muscular response that occurs when someone's under the influence of marijuana that can be useful for a field sobriety test. So if you generally, if you ask someone to track something back and forth, and then you bring that object, say it's a pen, you bring that tip of the pen towards their face and touching the tip of their nose, and you continue to ask them to track that with their eyes. For someone who is sober, their eyes will cross. For someone who's under the influence of marijuana, as they're tracking it as it touches the nose, one eye will cross in, but the other can't. The other will still kind of be looking forward. Why that happens, don't know, couldn't tell you. Don't know the brain mechanics of it, but their eyes can't converge or cross on an object that's right at their nose. So more potent psychedelics, such as LSD, mushrooms, can cause some pretty significant visual and perceptual disturbances. It also potentiates mood, so you got to be careful how you handle these folks. So someone who takes LSD and they're in a good, happy mood with a bunch of people around them, chances are they're going to be in a really good mood and a really up mood, and also seeing and hearing things that other people aren't seeing or hearing, but those hallucinations tend to be pleasant. For someone whose mood is depressed, anxious, nervous, isolated, alone, and they take a drug like LSD, what they will see and feel will be potentially disturbing or horrific to them. So if you have a kid that's freaking out, they just have to ride it out. These drugs tend to last quite a while. A dose of LSD typically lasts 8 to 12 hours. So for those kids, handle with care, put them in a calm, quiet place. For someone under the influence of those powerful psychedelics, their pupils also tend to be very, very big. So, as I mentioned before, there's some mood-altering behavioral processes or process addictions that can develop. Gambling, gaming, internet use, food, pornography, all have an addiction potential because they can significantly alter mood. And like a drug or a chemical, an individual can accumulate negative consequences in the pursuit of engaging in these processes. I have a therapist, a friend who specializes in working with gamblers. People making $40,000, $50,000 a year who come into treatment on average for $500,000 in debt, but they just need one score. They just need one big win to wipe it all away, and they keep chasing that high because they do get it on occasion. They do occasionally win, but the losses tend to accumulate and can be pretty significant. And with access to gambling or gaming or internet use as close as someone's phone, the abuse potential there is pretty high. It's harder to catch earlier because the impairment's more subtle and gradual as they engage more and more with it, and it's more easily kept secret because you don't have to worry about smelling like alcohol. You don't have to worry about coming home late because you were at a party because you could just be in your room. So it can be much more insidious and gradual, their descent into misuse or dependency on behaviors. So things to look out for with these sorts of things are absences, decline in academic performance. Those are the things that tend to go along for adolescents that are engaged in a process addiction as the behaviors become more important than other priorities. So with that, Dale, I don't know if you have anything to add, but that covers some of the highlights of things to be aware of and things to be on the lookout for, so you might know what you're dealing with when that dean brings that student to your door, kind of how to assess and determine what interventions need to take place.
Okay, thank you, Don. I do have a question, and it's in regard to marijuana because, as we know, with several states now legalizing recreational marijuana,
Hmm.
and some, including the state of Illinois, using it as a medicinal uh, medication.
Hmm. Yeah.
I'm curious about the increasing THC content of marijuana and how we see that changing how students might look when high.
Well, with with higher levels of THC in what's being used, so higher THC content drugs can include more potent forms of marijuana. It can include hashish, or hash, which is the resin from the marijuana plant, or hash oil, which is the oil that can be extracted from hash. These all have very high THC contents. Now, the thing about we talked about, marijuana tends not to causes alterations in our perception of time and spatial relations. When you're talking about the very high, 20, 30, 40, 50, 80% pure THC preparation, so to speak, you can actually experience hallucinations. It can, both visual, particularly visual hallucinations. So and another point to your point of things being legalized is a particular concern are edibles,
Mhm.
which are bakery or candies that have been infused with THC or pot, where the dosing is highly in inaccurate. So someone who's not aware of what they're eating could wind up taking a lot more than they intended or wanted to when you're dealing with an edible, because it's all hitting your system all at once. So it's not uncommon for us to see someone who is used too much of an edible to have an anxiety or a panic attack, because the change is pretty intense and pretty quick.
And we're seeing a lot of that out of Colorado. We're seeing a lot of ER admissions even as a result of some of those edibles.
Exactly. So now technically there's not a lethal dose of THC, but what happens are these behavioral reactions that can be pretty intense and pretty frightening,
Mm-hmm.
for someone that's it's and the thing is, our two legal drugs for those who are of age are tobacco and alcohol. Now, tobacco kills more people every year than everything else combined. You take tobacco out of the mix, alcohol kills more people than every other drug combined. Now we're having a third category that we're giving the veneer of that it's okay because it's legal. Now in Illinois, it's legal in certain circumstances for medicinal purposes, but the medicinal categories are pretty broad if you look at the legislation. Fortunately, some work was done to tighten it up a little bit before it went into law, and got rolled out. But it's still pretty broad categories, and there's nothing stopping someone from, going on a skiing vacation to Colorado and bringing back a bunch of edibles that were legally obtained in that state. So again, with the amount of advocates, pro-use advocates, that are being successful in getting this stuff legalized, either in general or for medicinal purposes, are changing the societal view of how okay it is, and minimizing the risks that go along with it.
And it is something that we'll need to continue to track as we work with young people. Thank you again, Don, for that presentation. Again, if you're interested in any other topics that you would like to see us conduct here on our webinars, please feel free to contact me at dale.gasperovic@prevention.org, and I'll be happy to work to get those webinars in and on our website so you can access those topics as you deem necessary. Thank you again for your time, and we look forward to seeing you on one of our other webinars. Thank you.